Welcome everyone, and thank you for joining us on the third day of this neonatal ventilation course. My name is Dr. Yasser Masood. I'm a consultant neonatologist in Shifa International Hospitals Islamabad, and Dr. Terry Cullen is a neonatologist based in Melbourne from Australia. Today is the last day of this ventilation course workshop. On the very first day, we discussed non-invasive ventilation, and that was an excellent presentation by Terry. Yesterday, we discussed conventional mechanical ventilation, and today we're going to talk about high frequency oscillation ventilation. So thank you, all of you who have joined us today for this session, and I'm hoping for a very good interactive discussion. We'll take questions at the end. Just as a disclosure that the faculty, speakers, and the CME department have no financial relationship with any of the commercial, any of the devices that we will mention in today's talk. So in today's talk, what we're going to do is we'll discuss and try to understand what high frequency ventilation is, what are its principles, and what should be the initial settings. What are the clinical indications where high frequency ventilation is used, and how do we adjust high frequency ventilation with regards to ventilation and oxygenation. Then finally, we'll discuss weaning and troubleshooting during high frequency ventilation. We'll start off with a case history. It's a 35-year-old lady with uncomplicated pregnancy who is induced at 41 weeks, and the CTG showed pathological CTG with both late and variable desolations, and there was thick meconium stained liquor, and an emergency C-section was performed. A 3.6 kilogram baby was delivered who was very floppy and covered with meconium. There was no respiratory effort at the time of birth. The heart rate was 70 beats per minute, and the baby's color was dusky, and he had poor peripheral perfusion. As per standard neonatal resuscitation guidelines, bag and mask ventilation was done, but there was very poor response. So the baby was intubated and large amount of meconium was suctioned. The baby was given positive pressure ventilation, with which the heart rate came up. The SATs improved. However, the baby was still needing 100% oxygen. The baby was admitted to NICU. So what we will do now, once we have admitted the baby to the NICU, so we'll optimize the ventilation, we'll look at the cardiovascular status, we'll assess the perfusion, and we'll start the baby on IV fluids. The baby might need inotropic support. We'll start the baby on antibiotics. Now, the first blood gas, which was done after admission to the unit, showed quite mixed acidosis with the pH of 7.03, high CO2, high base excess, and high lactate. The baby was then given 200 milligram per kg of surfactant and was started on SIMV ventilation, quite high settings. As you can see, the baby was needing quite high pressures up to 30/5 with I time of 0.5, still in 100% oxygen. And the blood gas at this point showed still ongoing acidosis, both respiratory and metabolic. However, despite baby being on such high settings and 100% oxygen, the saturation is still very low, 89 and 81% pre-ductal and post-ductal. The blood pressure is on the lower side. So this is a very common and quite serious problem that we come across in our NICUs. We know what is happening. The baby has got meconium aspiration syndrome and is showing signs of severe persistent pulmonary hypertension of the newborn due to meconium aspiration syndrome. And that's why there is such a significant difference between pre and post-ductal saturations. And despite such high settings on conventional ventilation, we are unable to oxygenate this baby. And that is demonstrated by low pre and post-ductal saturations. What are the options for this baby at this stage? If we are unable to oxygenate on such high settings in 100% oxygen, the next step would be high frequency ventilation. And this baby needs to be well sedated, plus minus paralysis. Also, he needs to be on inotropic support to raise the systemic blood pressure. If you're working in a developed country in level 3 NICU, The baby can also be considered for nitric oxide for severe pulmonary hypertension. And if all those things don't work and oxygenation remains poor, then the baby would be considered for ECMO. However, both nitric oxide and ECMO are not available for us. So we have to rely on high frequency ventilation and other supportive treatments to stabilize these babies. So what is high frequency ventilation? It's type of ventilation where we use a constant distending pressure, but the breathing rates are quite supraphysiological and the tidal volumes are quite low. In conventional ventilation, it relies on production of large pressure changes to induce flow of gas in and out of the lungs, and that can cause barotrauma and belly trauma. But in animal models, we have seen that the use of high frequency, so small volumes at a very high rate, leads to more uniform lung inflation, improved oxygenation, and that reduces the severity of lung injury compared to conventional ventilation. If we think about the evidence, as we speak, there is still no evidence from randomized controlled trials or systematic reviews that the use of high frequency ventilation in both preterm and term babies, both as elective or as rescue therapy, is better than conventional ventilation. However, we know from experience that whenever we have used high frequency on individual patients who have been very sick on conventional ventilation, the high frequency seems to have worked better. This is the meta-analysis which was published in 2015, and over 4,000 neonates were enrolled in this meta-analysis. And again, this failed to show any significant benefit of high-frequency ventilation over conventional ventilation. I think one of the reasons we still have no evidence to support that high-frequency ventilation is better than conventional, because the previous machines were very different from the machines that we have started to use over the last few years. And those machines use a different kind of mechanism to oscillate as compared to the machines that we use now. So I think over the coming years, as we get used to use more and more modern machines which use different types of mechanisms for producing oscillation, we will start to see the evidence in favor of high frequency ventilation compared to conventional ventilation, especially as a rescue therapy. So the conclusion of this meta-analysis was that there is very little marginal benefit of using high frequency ventilation as a rescue therapy. So what are the indications? So primarily it is used as a rescue therapy. I'm not aware of any units who use high frequency ventilation as a primary mode of mechanical ventilation. It is always used as a rescue therapy. So persistent respiratory failure despite high pressure conventional ventilation due to whatever underlying mechanism, underlying disease or pathology. And in these patients, the high frequency ventilation can improve the respiratory status, and it should always be a consultant decision to switch a baby from conventional ventilation to high frequency ventilation. So what are the indications? The commonest indications, the commonest is severe RDS in preterm babies. And usually these are the babies where mother probably did not have antenatal steroids, or the mother was septic, so the baby was born in poor condition. And in the absence of antenatal steroids, in the presence of sepsis, the babies tend to have severe RDS. And some of these babies, because the lungs are so solid, despite giving 2 or 3 doses of surfactant, they need high pressure ventilation and end up on high frequency ventilation. Meconium aspiration syndrome is another classical example where we use high frequency ventilation. And as I mentioned before, some of these babies, we can manage them just with high frequency ventilation, but the severe ones then go on to need nitric oxide, and some of them, a very small percentage, then end up on ECMO. Sepsis, again, is another condition where we can use high frequency ventilation. And because with sepsis, usually there's not only respiratory failure, but there's a multi-organ failure. There is also element of cardiac dysfunction. Some of these babies are very swollen, edematous. So and some of these babies have abdominal distension, subcutaneous edema. So in these babies, because of all these multi-organ involvement, high frequency tends to work better. Patients with congenital pneumonia. And then another group is quite a big group of disorders where there's pulmonary hyperplasia. And because their lungs are hyperplastic, those lungs are very difficult to ventilate and oxygenate on conventional ventilation. So in those situations, high frequency ventilation tends to work better. So the examples are congenital diaphragmatic hernia, especially the severe ones, mothers with a history of quite severe oligohydramnios due to whatever reason, babies with hydrops fetalis, and fetuses with congenital malformations like CCAM or pulmonary sequestration. So all these conditions, there will be an element of pulmonary hyperplasia. And if the pulmonary hyperplasia is very severe, usually the high frequency ventilation is required. Severe PPHN due to whatever underlying reason and air leak syndromes are the other indications for use of high frequency ventilation. We discussed this yesterday as well, that whether we are we're using high frequency or whether we're using conventional mechanical ventilation, the aim, there are two aims. One is ventilation, which is CO2 clearance that we want, normalish CO2 or a slightly higher CO2 in preterm babies. And our second aim is oxygenation, that we want to make sure that the preductal saturations are above 93 to 94%. So whatever we do on high frequency oscillation, these are our two goals, ventilation and oxygenation. So what is the principle of high frequency ventilation? How does it work? It's basically a small tidal volume at a very high rate that allows the primary goal of ventilation and oxygenation. And the simplest way to remember and to understand high frequency ventilation, and I'm sure Terry will remember, we have discussed this many times, how when we were trying to understand how high frequency ventilation works, that in simple words, it's CPAP with wobbles. That's how the high frequency ventilation works. And over the coming slides, I will explain this. So CPAP is your mean airway pressure. So this is the sustained inflation and recruitment of the lung volume by the application of constant distending pressure. And that helps to achieve oxygenation. So that's our mean airway pressure, or CPAP. And then the wobble is the alveolar ventilation and CO2 removal by using an oscillating pressure waveform on the map at an adjustable frequency at an adjustable amplitude. So that's what CPAP with wobble means. And this is the diagram which beautifully explains how the high frequency ventilation works. So this line, this straight line here is the mean airway pressure, and higher is the mean airway pressure, better is the oxygenation. This is the height of this is the amplitude. So higher is this line, higher is the amplitude that would lead to better CO2 clearance. So if the CO2 is very high, you can increase the amplitude. However, the relationship between the frequency and CO2 is different from conventional ventilation. So if the frequency is increased, say for example, from 10 to 12 or 14, when the frequency is increased, this curve will become narrower. When the curve becomes narrower, the area under the curve is small, and that reduces the CO2 clearance, and that will lead to high PCO2. So as the frequency is increased and the CO2 clearance is reduced, and that leads to high PCO2. So that's how these three things work. Higher mean airway pressure leads to better oxygenation, higher amplitude leads to low PCO2, and high frequency will lead to high PCO2, and vice versa. So the basics of high frequency ventilation is basically achieving and maintaining an optimal lung inflation. And optimal oxygenation is achieved by slowly increasing the mean airway pressure to recruit the lung volume and monitoring its effects on arterial oxygenation and saturations. And the aim is to achieve maximal alveolar recruitment, but without causing overdistension of the lungs, which needs to be carefully monitored with regular chest X-rays. So when we decide that the baby needs to be started on high frequency ventilation, these are the different settings that need to be adjusted: mean airway pressure, delta P, frequency, FiO2, and the DCO2 is not something that we need to set, but this is something that we need to monitor while the baby is on high frequency ventilation. So in terms of what mean airway pressure we should start the baby on, it depends that what was the mean airway pressure on conventional mechanical ventilation. And those who listened to yesterday's talk, that we spent a lot of time on discussing what mean airway pressure is. But on conventional mechanical ventilation, usually there is no knob as such to adjust the map. And there are other different parameters that we change to adjust the map up and down. But on high frequency ventilation, we can directly change the map by the knob or on the ventilator. So the initial settings are that if on conventional ventilation, if the map was say 12, we'll start the baby on 14 centimeters of water on high frequency ventilation, and then adjust subsequently based on the oxygen saturations and based on the blood gases. So that's kind of a rule of thumb to start 2 centimeters above the map on conventional ventilation. In terms of amplitude, the starting amplitude is usually around 20 or more until we see a good chest wall wobble. And usually we don't go above 60. So we'll start with the amplitude of 20 or 30 once we can see good chest wall wobble. And then based on the initial blood gas and based on the initial PCO2, we can then either go up or down on the amplitude. But as I mentioned, it's unusual to go on the amplitude above 60. And increasing the amplitude will increase the CO2 clearance and will lead to lower PCO2. The starting frequency is around 10 to 12 hertz. That's as a standard, but in some very preterm babies, we can start on a slightly higher frequency of 14 to 15 as well. That's the starting frequency. And the frequency generally is not changed very much. And we only change the frequency once we have manipulated the amplitude and there's still a problem with the CO2 clearance or CO2 retention. Only then we can manipulate the frequency. FiO2, usually these babies are sick when they need high frequency ventilation. So usually they will be needing higher amount of oxygenation. So that starting FiO2 will usually be high, anywhere from 60 to 80 to 100%. But then subsequently the FiO2 can be weaned according to the saturations. This is quite a new concept now, and that we see on the modern ventilators. I don't think that this was being used on the previous sensor medics machines. The DCO2 or diffusion coefficient of CO2 is basically related to the tidal volume on the high frequency ventilation and frequency. There is no set number. The trend is more important than the actual value. And there's an inverse relationship between the DCO2 and the plasma and the PCO2. So if suddenly the DCO2 goes up, that means the PCO2 will have gone down. So that means that you need to check if the baby is being overventilated, or if, for example, if the tube is blocked or if there is any kind of obstruction or the baby needs suction, what will happen is that the DCO2 will suddenly go down, and that will alert us that the PCO2 will have gone up, and we should either check a blood gas or think of either doing a suction or checking the ET tube. So this is quite a useful marker, which indirectly tells us that what is the PCO2 level at this time. And there's no absolute number, but it's the trend which is important. And there is inverse relationship between the DCO2 and the PCO2. Higher DCO2 means low plasma PCO2, and the low DCO2 means higher PCO2. Once we have started the baby on high frequency ventilation, it's important that the clinicians, they stay at the bedside, and very close monitoring for the is required initially. We need to monitor the saturations, the blood pressure, the chest wall movement, and the first blood gas should be done within 15 to 30 minutes of starting ventilation. And the first X-ray should be done after 1 hour to assess the lung expansion and to see the lung recruitment. What are the different kind of adjustments that might be required on high frequency ventilation? We might have problems with oxygenation, ventilation, air leak, and we might need to use slightly different settings if we're using it as a rescue therapy. And how do we assess lung inflation on high frequency? So this is, again, a very important diagram to understand how the oxygenation is done on high frequency ventilation. So if you look at the bottom of the graph, the point A is where the lung is underinflated. So a large change in amplitude is required, a large change in pressure is required to produce a change in tidal volume, to produce to recruit the lung. And this is clinically is shown by high FiO2 requirement and low saturations. And what we want to do is we want to move from point A to point B. So we want to recruit the lung. We want to inflate those underinflated alveoli so that a small change in pressure will lead to a significant increase in tidal volume. So that's our initial aim. But sometimes what happens in doing so, we might overdo it and we might go from point B to point C, which is overinflation. And when the lung is overinflated, it might not show up initially, but clinically, after the gases might not change, but after a while, we'll start to see that the cardiac output tends to drop. The patient might become hypertensive. The oxygenation will start to get worse. The saturation will start to drop. So we don't want to go to point C, and that's why the importance of keeping a very close eye on lung inflation by regular X-rays. And then once we have stabilized the baby on high frequency ventilation, what we want is we want to move from point B to point D, where the lung is adequately inflated and optimally recruited. That's where we can then start thinking of further weaning and moving from high frequency to either conventional ventilation or extubation. So that's our aim. So we want to move from point A to point B initially, get a period of stabilization, and then aim for moving from point B to point D, where the lung remains adequately inflated and recruited on lower pressures. But what we don't want to go to point C, where the lung is overinflated, and that will impair both oxygenation and CO2 clearance, and it will also affect the cardiac output, and that will be manifested by hypertension and raised lactate on blood gases. So as we discussed yesterday, the oxygenation is dependent on two parameters, which is mean airway pressure and FiO2. We on high frequency ventilation, we use a high volume strategy. So we tend to go for a higher MAP until we achieve a decent oxygenation or decent saturations. And as I mentioned earlier, usually these babies are on a higher amount of oxygenation. FiO2 is usually around 80 to 100%. In terms of optimizing ventilation, the two things which determine the CO2 levels, one is amplitude and the other is high frequency. If we increase the amplitude, that leads to lower CO2, it improves the CO2 clearance. And as I mentioned before, there is inverse relationship between the frequency and the CO2. So when we increase the frequency, the area under the curve decreases, and that leads to less CO2 clearance and increased PCO2. So there's inverse relationship between the frequency and PCO2 on high frequency ventilation. So to optimize ventilation or CO2 clearance on high frequency, we can change the amplitude. The new ventilators also tell us that how much tidal volume is being delivered with each breath, and the aim is usually around 2 mL per kilogram. And as I mentioned, the frequency is the parameter that we change once the amplitude has been reached to a maximum point. However, on some ventilators, like especially the Dagger ventilators, the amplitude cannot be increased above a certain point until the frequency is reduced. So in some cases, you might need to reduce the frequency from 10 to 8 to increase the amplitude above a certain number. For air leak syndrome, sometimes we might need to use a slightly low volume strategy by reducing the MAP and tolerating a higher FiO2 requirement until the air leak is settled. So as I mentioned before, for rescue high frequency ventilation, we use a MAP 2 centimeters above the conventional ventilation, and that then can be increased in increments of 1 to 2 centimeters of water. And our aim is to move from point A to B in the figure above. It will be quite unusual to need a MAP of 20 or more, but in some babies who are very, very sick, especially the ones who are waiting for an ECMO retrieval, sometimes in term babies, we have used a MAP of up to 25 to 30, but in those cases, you have to keep a very close eye on the blood pressure, on the oxygenation. But if the baby is very, very sick and there's no other modality available, then sometimes you have to keep going up on the MAP until you can oxygenate the baby. Once the high frequency ventilation is started, the X-ray should be done within an hour or so, and our aim is to aim for 8 to 9 ribs anteriorly. And if there are 10 or more ribs on the X-ray, that would suggest that the lung is overinflated and we need to come down on the map. And if they're less than 8 to 9 ribs or the diaphragm appears high, that means that there is underinflation. And in RDS, as the atelectasis improves, the oxygenation improves, the lung fields, they become more clearer. We shouldn't be very quick in assuming that high frequency ventilation has not worked. Sometimes these babies need a few hours until they can be stabilized on high frequency ventilation. As I mentioned, get a chest X-ray fairly quickly within an hour or so to assess lung inflation. And depending upon the initial blood gas and on the initial X-ray findings, then you can adjust the initial settings by either going up on the mean airway pressure or by adjusting the amplitude. The other important things that all other supportive measures in these sick babies should continue. So careful attention to the cardiovascular status, to the blood pressure, to the fluid and electrolytes. And most importantly, the babies on high frequency ventilation have to be really, really well sedated, unlike conventional ventilation. It will be very unusual for a baby not to be sedated on high frequency ventilation. And most of the time, if especially the ones where we are struggling with oxygenation, those babies will be paralyzed as well. And if you're really struggling with oxygenation or ventilation, ask for senior advice. Once the baby has been stabilized, then we can start weaning from high frequency ventilation. However, the key thing is that we need to make sure that we keep the lung volume during the period of weaning. The aim is initially to reduce the FiO2 down to 30 to 40%, and then slowly start reducing the MAP in decrements of 1 to 2 centimeter of water until the MAP is around 8 to 10 centimeter of water. And similarly, the amplitude is reduced based on the CO2. The frequency, as I mentioned before, is usually not changed very much. And once we are down to these settings where the FiO2 is less than 30%, the MAP is around 8 to 10 centimeters of water, the CO2 is good, the oxygenation is good. At that point, most of the time, the babies will be changed from the high frequency ventilation to conventional ventilation. But in some cases, if we think that the baby's lung condition has improved significantly and the baby does not need to be on the ventilator anymore, there is a possibility that some babies might be extubated directly onto CPAP from high frequency ventilation. But that again is a decision which depends upon the individual baby's lung condition. Most babies will be extubated, will be stepped down to the conventional ventilation first. These are the two different devices which are the one on the right side of the screen is old sensor medics machine, and the one on the left side of the screen is one of the Drager ventilators. And on the beauty of the modern ventilators is you can use the same machine for conventional and the same machine for high frequency ventilation. Previously, you had to use a totally different machine for high frequency ventilation. So a few troubleshooting things. If we are struggling with oxygenation and the PO2 is low, we need to make sure the ET tube is patent, the baby doesn't need suction, there's not a significant leak around the ET tube. Look for the chest wall movements, breath sounds, and consider increasing the mean airway pressure slowly in increments of 1 to 2 centimeter of water. If we're suspecting that there might be an air leak or a pneumothorax, look carefully at the chest wall movements, transilluminate, and get an urgent chest X-ray. If there is suboptimal lung volume recruitment, then we need to increase the MAP and assess the inflation of the lung and the degree of recruitment on chest X-ray. If on chest X-ray the lungs appear overinflated, then slowly reduce the MAP. And in some cases, you will see that the oxygenation will improve. If the PCO2 is high, then you need to make sure that again the ET tube is patent, there's no air leak, and then the first step would be to slowly increase the delta P in increments of around 3 to 4, and that should slowly improve the CO2 clearance. You might, if you're struggling with CO2 clearance, you might need to come down on the frequency in these cases. One of the other reasons that the PCO2 might be high that we are at point C in this diagram. So if the lung is overinflated, that not only interferes with oxygenation, but it also interferes with ventilation as well. So again, you have to be careful that the lung is not overinflated if we're struggling with the CO2 clearance. And if all of the above things we have worked, we have checked, we have optimized the delta P, the lung is well inflated, then we can think about reducing the frequency. And generally, we don't tend to go below 8, but in exceptional situations, we can go down to 7 or 5. But generally, most people will not go below 8 on the frequency. And if there's persisting acidosis and hypotension, then think of, again, overdistension, reduce the MAP, and consider chest X-ray. And judicious use of inotropes, because most of these babies, when they're so sick, there will always be an element of myocardial dysfunction and an element of pulmonary hypertension. So we need to make sure that the systemic blood pressure is fairly decent. So the key points are, as we discussed, that there's no proven benefit on the mortality for elective high-frequency ventilation compared with conventional in preterm babies, and the level of evidence is 1. If a lung protective strategy of conventional ventilation is used, there's no difference in chronic lung disease between high-frequency ventilation and conventional ventilation in preterm infants. Again, the level of evidence is 1. Low-volume strategies for high-frequency ventilation are not recommended, and great care must be taken to avoid overexpansion of the lungs, and signs of this should be assessed clinically and with regular 12-hourly X-rays. That's level 3 evidence, and there's no RCT evidence to support the use of rescue high frequency in preterm or term infants. That's level 1 evidence. But as I mentioned earlier, all these trials and systemic analysis, meta-analysis have been done when we were using old machines, which is like sensor medics. So the patient population now is very different, because we're now using, we are using better machines, which are more modern. I think over the next coming years, we probably will start seeing much better evidence in favor of high frequency ventilation. There's something which is again coming up in practice in some units as well, is as we discussed yesterday as well, that they, just like volume controlled ventilation, there's a volume guarantee high frequency ventilation as well. And just like on conventional ventilation, on high frequency ventilation, if it's volume guided, you tell the ventilator that you want a certain tidal volume with each breath, which is usually 2 mL per kilogram. And then the machine will then other settings like amplitude and mean air pressure, the machine will then decide. But this is something which is not in routine practice now, but over the coming years, as we become more and more familiar with new ventilation techniques on high frequency, this will become more in practice. So that brings us to the end of today's talk. We will now take some questions. But before we go and take those questions, I just want to mention that after the end of this 3-day course, if there were any questions or queries, or if any in future, if you need any advice, I'll put my email address and my Facebook page there. You can contact either through the email or through the Facebook page for any kind of advice or any questions related to this ventilation course. Thank you.
Thank you, Yasser. I wanted to make just a couple of comments, if that's okay, before taking questions. You mentioned for babies who require high frequency support, the need for paralysis, potential need for paralysis and sedation. And of the two of those, the sedation really needs to come first. Inducing total muscle relaxation with, for example, vecuronium or atracurium without providing adequate sedation to a child is very uncomfortable for them indeed. So something like morphine or midazolam needs to be within a therapeutic range if you are going to embark on that level of therapy. And I wanted to clarify one comment from yesterday's talk, given the nature of some of the questions that we had. All ventilators use pressure to deliver volume to children. Okay, and what we used to do was deliver set pressures and give essentially variable volumes. And volume is what causes trauma to the patient's lung if it's too high. With targeted tidal volumes, you deliver a set volume and modify the pressure accordingly. And the rationale for that is that it's better for the lung and for the child's ventilatory development. All right. Now we've got a number of questions here so far. First from a Dr. Aisha Moin. Please advise about ventilator settings in pulmonary edema with regards to which parameters should get special attention.
So I think if you're using conventional ventilation, you would try to use a slightly higher PEEP in these babies because they've got that lungs. But other than that, the other settings will be more or less the same as in other babies. That would be dictated by the degree of pulmonary edema, how much oxygenation problem is, and how much is the CO2 clearance problem. But generally, these babies will need a slightly higher PEEP than other babies.
What is the outcome of pulmonary hyperplasia? Because hyperplasia is not going to improve.
So that depends what is the reason for pulmonary hyperplasia. So we have seen that if you can manage for the first few days on high frequency ventilation with nitric oxide, if you can stabilize, then these babies then over a period of time tend to grow a little bit. But certainly these babies are very difficult to ventilate and oxygenate. And so the degree of pulmonary hyperplasia is important. The severe ones probably will not make it, but those with a moderate degree of pulmonary hyperplasia, especially if the underlying cause is like, say, congenital diaphragmatic hernia, if the CDH is causing pulmonary hyperplasia, and if we can stabilize the baby for, say, 24, 48 hours and manage to operate on the baby, and then those are the babies who might be able to survive. But I think you're right that the pulmonary hyperplasia is not going to get better, but if you can support the baby for the first few days with whatever form of ventilation, then those babies do have a chance of survival. And we've seen babies with severe pulmonary hyperplasia have been very, very sick and have needed significant ventilatory support, but then subsequently have managed to wean and then extubate. Do you agree, Terry?
It's very much a spectrum in terms of severity. And you've got to wait and judge them on the clinical picture. You know, you may look at an X-ray and think, you know, this doesn't look good, but the proof is in the pudding. You know, you give the child 24, 48, 72 hours and see their response to treatment, and then you've got a much clearer idea of exactly where you stand with them in terms of the severity of the condition or how amenable it is to treatment. Dr. Gill asks, is fentanyl available in Islamabad?
Yes, the fentanyl is available, and we are using it as infusion and as a bolus as well. Yes.
Good. How long should we wait for on SIMV mode before going to high frequency?
I don't think there's a set answer to that question. You need to, first of all, you need to know what is the patient's pathology and how much pressure you are needing on the SIMV. It depends upon the individual patient condition. If you've got a baby, for example, with severe meconium aspiration and PPHN, I think the case that I mentioned, I think you have to decide in the first few hours, as soon as you have maximized the conventional mechanical ventilation. If you have the facility to use high frequency ventilation, there's no point in waiting. So as soon as you have maximized the settings on conventional mechanical ventilation and you have not seen any response, then there's no point in waiting. And if you can, and you have got the facility to do high frequency ventilation, then you should move on to high frequency ventilation.
I think certainly if you're delivering a peak inspiratory pressure over 30, that should be a trigger to think, actually, can we be delivering these high levels of pressure more gently to the lungs? And high frequency does that.
In term babies, as soon as you reach a PIP of around 30, and in preterm babies, as soon as you reach a PIP of 25, and you will know that if you're using pressure control ventilation, you will know that straight away. And if you're using volume guarantee ventilation, you will know that how much PIP you're needing to deliver that at a volume. So just keep these numbers in mind. A PIP of 30 for a term baby and a PIP of 25 for a preterm baby. At those numbers, you need to start thinking the baby probably need high frequency ventilation.
A question here that I don't fully understand from Dr. Adam. Tell me how we would ventilate a COPD patient on ventilation. COPD, to my understanding, if it's the same terminology that we use in the UK, refers to smoking-related illnesses of the elderly, not also the neonatal population.
I don't see COPD is adults' problem, so I'm not sure we can answer this question.
Okay. we've got a question of, well, what are the reasons for RDS in many babies' cases?
So surfactant deficiency is the reason for RDS in all preterm babies.
Yeah. And a question regarding the ET tube fixing formula. A rough rule of thumb is 6 centimeters plus the baby's weight in kilos, but you would correlate that with auscultation, end-tidal capnography, and of course a chest X-ray. We've got a question here. If high frequency fails, then do we have to move towards conventional ventilation?
So it depends what facilities do you have and why you are using the high frequency ventilation. If you don't have the facilities for inhaled nitric oxide or ECMO, as we don't have, then if the high frequency ventilation is not working, then you have to move back to conventional ventilation, and that probably is a poor prognostic sign, because that baby is not improving on high frequency ventilation, is certainly not going to improve on conventional either. So that certainly is a poor prognostic sign. But if you have got the facilities for inhaled nitric oxide or ECMO, then if the baby is not stable on, or is not oxygenating or ventilating on high frequency ventilation, then those are the ones which need ECMO referral.
Got a question here: how to set high frequency settings in a conventional ventilator? I guess the answer is that firstly you need to change the mode to the high frequency mode. So not all ventilators offer this. So it's not a case of changing those settings per se. It's a completely different mode of ventilation altogether.
Yeah, so the ventilator, they need to have inbuilt ability to do high frequency ventilation. So I think that's only available in the modern ventilators like SLE 5000 or Draeger. If you're using the old style conventional ventilators, then they don't have the facility to deliver high frequency ventilation. So you can only do mechanical ventilation by conventional method on those ventilators.
And one further question: what is the use of the trigger in the ventilator settings?
So we use mainly flow trigger. People previously have used all different sorts of triggers, but on conventional ventilation we use flow trigger, so that when the baby is trying to breathe, once the flow reaches above a certain flow rate, at that point the ventilator will support the baby's breath.
All right, those are all the questions so far.
Okay, I think that brings us to the end of this session and to the end of this course. And Terry, thank you very much for your time over the last 3 days, and thank you to all the participants over the last 3 days, and for very interesting questions at the end. As I mentioned, if there are any more questions in future, please do contact me through my email. And thank you very much. Thank you, Terry.
Thank you, Yasser.